about, yes, SGLT2 inhibitors in diabetes, and then vildagliptin in the role of diabetes and NASH. We now have pioglitazone, which is one of the age-old molecules. And when we compare it with the newer class of molecules, so this has been a molecule which has been there with us from a number of years. Some years back, it went into disrepute for its for the controversy related to bladder cancer. But now we must say that pioglitazone is clear of all the myths that has been associated with it. And we now have this molecule which is there with us and is available at a very cheap, lower cost for the treatment of not only diabetes, but it also has a proven role in the treatment of non-alcoholic steatohepatitis. Now, there are very few molecules which are effective for the treatment of non-alcoholic fatty liver disease. Lifestyle modification is one of the most important factors which improves non-alcoholic fatty liver disease and is one of the key management factors to address non-alcoholic fatty liver disease. Other than anti-diabetic agents, so apart from lifestyle modification, there is nothing much, I would say, for non-alcoholic fatty liver disease. It becomes more of a metabolic disease, and hence it belongs more to the arena of endocrinologist and diabetologist rather than gastroenterologist. Why we say so? It is because now there's this common soil hypothesis where we believe that most of the metabolic diseases, they kind of appear in the same individual because of the ingredients which are required, which are same for the individual who also has diabetes. He's also more likely to have hypertension. He's more likely to have cardiovascular disease, and he is more likely to have non-alcoholic fatty liver disease. So with the newer medications and with this age-old molecule, pioglitazone, we now have, as diabetologists, we now have more weapons with us to address non-alcoholic fatty liver disease than actually gastroenterologists. So we have pioglitazone, we have GLP-1 receptor agonist, we also have SGLT2 inhibitors, which are new molecules which are in the pipeline. And there are small studies which Dr. Chakravarti has shown to show the role of SGLT2 inhibitors in non-alcoholic fatty liver disease. One of the oldest molecules being pioglitazone. So we know there's a rising prevalence of non-alcoholic fatty liver disease and NASH. And there is a key connection between type 2 diabetes and non-alcoholic fatty liver disease. What are the contributors to non-alcoholic fatty liver disease? It is the lifestyle, the level of activity which a person has, that is whether the patient has a sedentary lifestyle or a more active lifestyle, food availability, exercise availability, dietary factors, and also genetic polymorphisms, gut microbiota, and dietary intake of saturated fat versus polyunsaturated fatty acids. They play a key role in determining the existence of non-alcoholic fatty liver disease. Now, when we see what is the algorithm for evaluation for patients who are at risk for non-alcoholic fatty liver disease, one of the most important algorithms is measuring the BMI of the patient, finding out whether he has central obesity. The waist circumference can help, the neck circumference can help. So as Dr. Lakshmi had said in the previous talk, that we Asians have a thin fat phenotype, where though we have a lesser BMI, we have central adiposity, and hence we are more at a risk of cardiovascular diseases as well as non-alcoholic fatty liver disease. So a simple physical examination where we find hepatomegaly, a simple screening test like ultrasound which can show fatty liver, and the patient's BMI can be quite indicative that this patient also has hepatic fibrosis, which is a serious issue. Now, FIB4 is a important and is an easy tool with which we can assess fatty liver. So depending upon that, non-invasive testing for fibrosis, that is a FIB4 score, we can classify patients as low risk, intermediate risk, or high risk. If the patient is in the intermediate risk or in the high risk group, then we can ask him to do a elastography or a fibroscan, which can give us the fibrosis score. Now, the initial evaluation, the most important initial evaluation of a patient with non-alcoholic fatty liver disease would be his BMI, the medical conditions which he has associated, the current medications, family history of diabetes, a family history of non-alcoholic fatty liver disease or cirrhosis, alcohol use, the amount he is using, the pattern of use, and also obstructive sleep apnea. Why we have to inquire about all these conditions? It is because these metabolic diseases are frequently associated with non-alcoholic fatty liver disease. Physical examination would give us an idea about the body fat distribution, whether he has central obesity or he has peripheral obesity. And certain simple laboratory tests, like doing a liver function test, which would give us the SGOT, SGPT levels, doing a platelets test, these will and would give us an idea about the fatty liver in the patient, that is the steatohepatitis. Screening is recommended in type 2 diabetic patients in metabolically complicated obesity. NFLD in the context of moderate alcohol use, we also have to keep in mind, because having isolated NFLD is also sometimes, it can be difficult. And then first degree of a relative of a patient with cirrhosis due to non-alcoholic fatty liver disease or NASH. Now, what are the parameters for non-invasive assessment of non-alcoholic fatty liver disease? Imaging like ultrasound, a fibroscan, MRI can be done, which is more specific for fatty liver. And then when we look into the potential medicines which are available for treatment in patients with non-alcoholic fatty liver disease, one of the molecules which is known to everyone is vitamin E at a dose of NASH without diabetes or cirrhosis, but there is a risk of hemorrhagic stroke and the risk of prostate cancer. Pioglitazone at a dose of 30 to 45 milligram per day is effective for non-alcoholic fatty liver disease, and we'll be going into the scientific evidence part of pioglitazone in this disease. It can be used in patients with NASH with or without type 2 diabetes. It leads to improvement in steatosis, the activity score, NASH resolutions, and also fibrosis resolution has been seen. Non-liver related fronts includes improvement in insulin sensitivity and CV risk reduction, and also stroke prevention. It does have a cardiac benefit, though we do not see a cardiac benefit with vitamin E. Of late, GLP-1 receptor agonists have been one of the forerunners in the treatment of non-alcoholic fatty liver disease, because they also lead to a weight improvement in steatosis, liver steatosis. It doesn't have a proven impact on fibrosis. Non-liver related improvement in insulin sensitivity, weight loss, cardiovascular risk reduction is seen. And as we heard in the previous talk, these molecules like liraglutide, GLP-1 receptor agonist, can slow the progression of medical renal disease. So pioglitazone in NASH, let us look into the clinical evidence which this molecule has. So in this New England, in this study which was published in NEJM in 2006, this study was done with 55 patients with IGT or type 2 diabetes and liver biopsy proven or confirmed NASH. This treatment was of 6 months duration with a hypocaloric diet along with pioglitazone at a dose of 45 milligram per day. There were 2 arms, one with a diet modification and pioglitazone, and other with a hypocaloric diet plus placebo. And these patients were evaluated for hepatic histologic features and hepatic fat content by MR spectroscopy. In this study, the revelations were quite encouraging, and it was quite good. There was a decrease in the plasma AST and ALT levels, and there was a decrease in hepatic fat content by MRI, and it was significant with pioglitazone compared to placebo. There was an increase in the level of adiponectin, and when you look into the placebo and healthy control and pioglitazone, you see that pioglitazone, the adiponectin levels reached almost similar ranges as healthy control after use of pioglitazone compared to that of placebo. When we look into the liver-related front, there was improvement in inflammation, there was decrease in ballooning, necrosis in the biopsy, and that was all seen in biopsies. There was improvement in steatosis and there was improvement in fibrosis also. If you see, all these scores are clinically significant where the P is less than 0.001. So inflammation, ballooning necrosis, steatosis, as well as fibrosis. So it was seen that diet with pioglitazone improved the glycemic control, acted on the glycemic front. It normalized the AST, ALT values. It decreased the hepatic fat content, improved hepatic insulin sensitivity, and also improved histologic findings like steatosis, ballooning necrosis, inflammation. And there was greater reduction in necroinflammation, 85% compared to 38%. Again, in another study, which was done for 18 months, and then it was continued for 3 years. The long-term effect of pioglitazone treatment was seen in patients with NASH and pre-diabetes or type 2 diabetes. In this, also biopsy-proven NASH were recruited. And the patients were prescribed a hypocaloric diet and then randomly assigned to pioglitazone 45 milligram or placebo for 18 months. The primary outcome was reduction of at least 2 points in non-alcoholic fatty liver disease activity score in 2 histologic categories without worsening of fibrosis. And secondary outcome was histologic outcomes along with hepatic triglyceride content measured by MRI and metabolic parameters. Now, when the outcomes were seen, it was seen that in the primary outcome, more than 2-point reduction in non-alcoholic fatty steatohepatitis score, it was seen that pioglitazone brought about significant reduction in more than 2-point reduction in the score in 58% compared to 17% in placebo, which was statistically significant. And when we looked into the secondary outcomes, steatosis, there was more than 1-point improvement, which was again greater in the pioglitazone group compared to placebo. Inflammation was again reduced to a greater extent with pioglitazone, and ballooning was reduced to a greater extent, and fibrosis was also reduced to a statistically increased extent, ballooning, inflammation, and steatosis. And there was an improvement in fibrosis, which was, however, not statistically significant. But the numerical value of reduction in fibrosis was greater in pioglitazone group compared to the placebo group. So it was seen from this study that long-term treatment with pioglitazone was safe and effective in patients with pre-diabetes or type 2 diabetes and NASH. Along with improvement in the liver profile, the weight was similar in the placebo and the pioglitazone group. So after treatment, after 18 months or 1.5 years, fasting plasma glucose decreased in the pioglitazone group. If you see in the placebo, it was 119 after 18 months, and it was 110 in the pioglitazone group after 18 months when they studied. 2-hour PPG was reduced from 216 in the placebo and 173 in the pioglitazone group. Likewise, there was a reduction in HbA1c. There was improvement in the fasting insulin level, free fatty acid, liver fat content, AST, ALT levels. Triglycerides were also reduced with pioglitazone, the blood triglycerides, serum triglycerides. And LDL cholesterol was almost similar between placebo and the pioglitazone group. And when you look into the HDL, that was also similar between the pioglitazone and the placebo group. Now, in this study, they also studied the liver fat and insulin sensitivity before and after 18 months of pioglitazone. Liver triglyceride was statistically significantly reduced. Hepatic insulin sensitivity improved. Muscle insulin sensitivity also improved, and as well as adipose tissue insulin sensitivity. The plasma AST, ALT score improved. HOMA IR score improved, and adipose tissue IR score also improved. So from this study, it was seen that 3 years of pioglitazone treatment was associated with long-term metabolic and histologic improvement in patients with pre-diabetes or diabetes and NASH. Results suggest that NASH progression may be halted and natural history of the disease can be modified with the use of pioglitazone in these patients. a systematic review and network analysis, meta-analysis, where they did a comparative efficacy of pharmacologic therapies for fibrosis improvement in and resolution of NASH, showed that for NASH resolution, sema, liraglutide, and vitamin E plus pioglitazone had the highest probability of being ranked the most effective intervention for achieving NASH resolution. Pioglitazone and vitamin E were significantly better than placebo in achieving at least more than one stage improvement in fibrosis. So what do the ADA 24 recommendations suggest? That pioglitazone or GLP-1 receptor agonists are the preferred agents for treatment of hyperglycemia in adults with type 2 diabetes and biopsy-proven NASH, or for those with clinically significant liver fibrosis using non-invasive test. Statements from ADA also states that early diagnosis and treatment of non-alcoholic fatty liver disease offers the best opportunity for cirrhosis prevention. Pioglitazone and some GLP-1 receptor agonists like liraglutide, semaglutide, tirzepatide have shown to be effective to treat steatohepatitis and may slow fibrosis prevention and progression, and also have a beneficial effect on the cardiovascular risk profile, which is the #1 cause of death in patients with type 2 diabetes and non-alcoholic fatty liver disease. So these molecules, like pioglitazone and GLP-1, they not only address the non-alcoholic fatty liver disease axis in type 2 diabetes, but they also have a positive influence on the cardiovascular disease. Pioglitazone improves glucose and lipid metabolism and reverses steatohepatitis. Fibrosis is also improved in some trials. A meta-analysis concluded that pioglitazone treatment results in resolution of NASH and may improve fibrosis. It halted the accelerated pace of fibrosis progression in type 2 diabetes and NASH. So what is the take-home message? We see that NASH, from the previous discussions, we see that the cause of non-alcoholic fatty liver disease is multifactorial, and treatment still remains challenging because none of the drugs have a full effect or 100% effect in reversing non-alcoholic fatty liver disease. The major factor in causing non-alcoholic fatty liver disease is the increase in liver triglyceride content caused by chronic release of free fatty acids from insulin-resistant dysfunctional adipose tissue. Pioglitazone targets insulin resistance, adipose tissue dysfunction, and inflammation that promotes hepatic lipotoxicity. In several clinical trials in NASH, pioglitazone was effective and very well tolerated. Thus, pioglitazone can be a more suitable alternative, more economical alternative, and more widely available alternative for treating steatohepatitis in patients with NASH, because as of now, GLP-1 receptor agonists still remain out of reach of the vast number of patients who have non-alcoholic fatty liver disease. So along with lifestyle modification, which plays a key role in reducing non-alcoholic fatty liver disease, amidst the drugs, especially drugs which are also effective in type 2 diabetes, we have age-old pioglitazone, which is not only available, is economical, but is also backed by scientific evidence and is recommended by guidelines. With that note, thank you for the patient here.